Well, good evening. I am Anne Arundel County Executive Steuart Pittman, and I am here with our Anne Arundel County Health Officer, Dr. Nilesh Kalyanaraman. And this is our every other week Tuesday night that I do on various topics. We started this out at the beginning of the coronavirus pandemic back in March, and it was originally just Nilesh and myself with some additional guests on the pandemic. And we're back where we started with Dr. K and me, and we're doing a little bit differently than we've done it in the past. We're gonna have a conversation. Nilesh is gonna go through some slides with some graphs and charts and metrics and things that we've done, and then we're gonna dig into about 10 pages of questions that we have here. I have on my screen that people have sent in advance. If you put questions into the Facebook chat, we have somebody who will pull some of those and send them over, especially if they're questions that are on topics that haven't quite been asked the way. So we'll get through as many of those as we can. We probably won't reach them all because there are a lot, but we do want to spend a fair amount of time on that. And I just want to say before Nilesh starts that the moment we're in, the way I see it is that we're all a little bit weary of this pandemic. We wish it would just go away. When it started back in March, I remember feeling a sense of really almost bewilderment. We were facing something that we didn't know much about. We knew what we had seen in the news in China, what we'd seen in Italy, and what we saw happening in New York City. And it was very ominous. And we were trying to identify locations throughout the county to quarantine and isolate large numbers of people, sick people. We were booking hotels, rooms, and we were having weekly conversations with two hospitals in the county, two major hospitals, about their capacity. They were setting up tents and trying to find ventilators, and the governor instituted a stay-at-home order, first closed schools, and it worked. And we really did flatten a curve that was going almost straight up fairly quickly, and we pushed it back down again. And as you'll see, as we start to go through some of these metrics, it got pushed down. It started to come up again during the summer. It's gotten pushed down again. It started to go up again. There are lots of factors involved in that we're going to talk about. But I want to say that my goal in all of this has been first and foremost to save lives. And I think that we cannot forget that there are 200 plus, we're closing in on 250 people in our county who've died of coronavirus. We have 190, I think up to almost 194,000 in the country who've died, and some are projecting that by the end of the year, at our current rate, if we don't change what we're doing, that we'll hit 400,000. So that's around 1,000 people a day. It's not gone away yet. We're at numbers that were higher than when we started, when we were very concerned about this, so that if spread increases to the rate of spread that we had in the beginning, we'll be in a very bad place quickly. So my view is that while we've figured out how to live with this, how to open businesses have figured out how to operate safely without spreading. People are getting used to wearing masks. We're trying to figure out how to get schools open with rates of spread that are pretty close to what we have or a little lower than what we have. We're trying to push them down so that we can do that. We're still at risk, and we still have people who are likely to die of this, and we want to save as many lives as we can. So that's the context. That's the environment we're in, and I hope people don't forget that. It's not alarmist to say that we're working to save lives here, and we're working to keep people from getting sick. So that's why we have a health department. We have really, I think, I'll have to say we have the best health department in the state of Maryland, in my view. But I haven't spent much time with the others, so I'm not trying to belittle anybody. But what I've seen go on in our health department with Dr. Kalyana and the team there is, the only county to really implement contact tracing universally from day one, and to not only do the kind of contact tracing where you have people from a phone bank making calls from out of state to our people who have tested positive, but we have people managing the quarantine and the isolation and helping people get through that and figure out how to do the isolation that they need, and their local people doing that work. And that's really important. And we've grown that team. Um, and our team has been at the forefront. They've been able to increase testing. When they said we were testing less than 1% of our population a week, the goal was set to test 2% and managed to get there within 2 or 3 weeks. Really impressive work by everybody. And then I have to say that throughout county government, our health and human service agencies, all of county government has stepped up. Everybody's job description changed. Everybody started delivering services that we didn't have to deliver before. Huge amount of food distribution that's still going on, working to prevent evictions from people who are particularly renters who are at risk of eviction. And first in the state to set up a program for that. And I'm really proud of the work that county government has done. And this is a time where people really realize how important it is to have effective, efficient government working to protect the residents. So with that, I will turn it over to Dr. K, who will take us through some of these slides. I'm going to jump in on some of that as well. We'll try to make it a little bit of a conversation, keep it lively, and then we'll cover some of the questions we have. Dr. K.
Thank you, County Executive. It's good to be here with you this evening. And I also want to just give thanks and acknowledge the work of everybody at the health department who has been working hard and putting in a lot of extra hours and effort during this pandemic. It's been nothing like anything we've ever seen before. And we're going to continue to do that. So my thanks to everybody at the health department and in county government for everything they're doing. I'm going to do a share screen, so give me 1 second. Bear with me. Want to share some slides just to walk through some of the things that we're seeing in terms of. Let's see if this works. There we go. In terms of what our priorities are, what we're doing from a health standpoint, we're really looking to make sure we can keep Anne Arundel open by preventing illness and death. And I think that that's still crucial, even though we've learned a lot in the 6 months since COVID has been in our county. We're still learning more, and it's an ongoing process. As part of that, we really want to allow schools to open in person. The development of children is really critical, and that's why we've highlighted that as one of our core goals. We want to keep businesses open. The economic security of people throughout the county is also critical, and promoting mental and social well-being, and that's obviously really difficult during a pandemic where our normal social routines have just been completely disrupted. And then core to all of this is prevention. How do we prevent the spread of this so that we're not treating? That's what public health is all about. And so when we look at the COVID-19 symptoms, it's been a while since we've talked about this, but I think it's useful to remind ourselves of what we're looking at, particularly as we're entering into cold and flu season. There's a wide range of symptoms, and it takes anywhere from 2 to 14 days after exposure, usually an average of about 5 days, for people to manifest symptoms. But one of the things we also know is that not everybody does. So when you do exhibit symptoms of COVID-19, they can range from fevers, chills, to cough, shortness of breath, fatigue, muscle or body aches, headaches, a new loss of a taste or smell, sore throat, congestion, nausea, vomiting, or diarrhea. As you can tell, it's a pretty broad set of symptoms. And when we started in March, it was a much shorter set. And what we've seen is that we've learned more about how it's manifesting, including that some people don't actually have any symptoms. The other thing that we've learned is that it has had a major impact on us from a health perspective in terms of death. It is the fifth leading cause of death in Anne Arundel County. So the last year for which we have full data is 2018. We're waiting for our 2019 data. But if based on that, COVID would be the fifth leading cause of death. And we just came to our county in March, and we still have 3.5 months left to go. Um, in the United States, it's the third leading cause of death already. And so it's had a massive impact. And this is part of why we have reacted to this pandemic so forcefully. One of the positive things that we're seeing is that the death rate is decreasing due to improved hospital care and treatment, but there really isn't any outpatient treatment. And so that's why we focus on prevention and preventing people from getting this to begin with. I think another thing that we're learning and that we need to pay more attention to going forward are the folks we call long haul survivors. So, for the people who have severe symptoms, severe enough to require hospitalization, we're seeing that they have persistent symptoms afterwards that affects many different parts of their body. And in fact, most studies have shown that, all studies have shown that a majority of people who've been hospitalized have some long lasting symptoms afterwards. Now, one of the things, of course, is that we've only been about 9 months globally into this pandemic. So we don't know how this story is going to finish out. But already we're seeing neurological symptoms, things like mental fogging, just feeling cloudy, uh, lung problems, including shortness of breath and cough, cardiovascular problems, including heart inflammation. And so it's not just death that is a consequence of this. It's also longer term effects that can be really debilitating. And there are clinics popping up to address this at academic medical centers to really provide the care and understand what's happening. I think one of the things that we thought at the beginning was that this is similar to the flu. We've really seen that COVID, the virus that causes it, the coronavirus, really has very different actions in the body than the influenza virus that causes flu. They manifest as some of the same symptoms, but what happens to your body is really different. And so that's just a key thing to understand going forward. So let's transition into understanding some of the data that we use sorry about that, to understand how we are doing as a county, and to help in our decision making. You may have noticed that about a month ago, we switched to using a case rate. A case rate really is just a different way of looking at the number of cases per day. So why do we use that? A case rate is calculated by taking your cases per day and calculating how many cases do you have per 100,000 per day. Our population in Anne Arundel County is 579,000. And so we use that. So how do we use that? Let's say we had 100 cases today, and let's say Montgomery County had 200 cases. Well, because their population is about double ours, we would have the same case rate. And so it gives us an easy way to compare how different counties or counties and states are doing compared to each other. For general reference, a case rate of 10 means that we had 58 new cases that day. And this is a 7-day average, so it tries to smooth out some of the bumps. But we found that it's really been adopted widely across the nation. Of course, the governor noted it as well as a key metric. And it's a way to understand, particularly when we talk about schools, how we're making decisions around that. And we'll talk a little bit more about the case rate in a couple of minutes. Hospitalizations we track, that's available on a recovery dashboard. And we've seen in the past week a slight increase in our hospitalizations. This is also one of the key measures we look at. Generally, we found that when you see cases start to increase, it takes about 2 or so weeks for your hospitalizations to increase. Then another 2 weeks later, you'll see ICU stays increase. And then another 2 weeks, you'll see deaths start to rise. Some of that has shifted of late because of the age of who is getting sick. Percent positive is also a measure that's used a lot. It's a good measure, but the case rate is really the primary measure we look at. The percent positive simply looks at how many people were positive over how many tests were done that day. So it's a good way of trying to understand if you've got enough testing in the community to be able to catch as many of the cases as possible. And we want that under 5, and we really want it as low as we can get it, but definitely under 5. And then the infection rate is one that we look at. It helps give us an understanding of what's happening. It is not something we ourselves calculate. You can see at the bottom that there's a URL, a website that you can go to see this. And the way to think about this is that if the infection rate was 1, each person would only give it to another person. And so you would, in essence, have the same number of people getting sick each day. As that goes above 1 and goes higher and higher, you'll see more and more people getting sick each day. If that goes under 1 and goes down, you'll see fewer and fewer people getting sick each day. So what we really want is that infection rate to go down as much as possible, but certainly less than 1. So it's not a measure we can control directly, but it gives us a sense of what is happening. And right now we are above 1.
Let me just note on that slide that if you can't read the website, it's covidactnow.org. And you can type in any jurisdiction in the country or a state. And there are a number of really interesting charts there. And they tell you whether we're at a stage of what they consider to be high risk or medium risk or critical risk. And Anne Arundel and the state of Maryland are in the high risk category right now.
And then we also have some data from our contact tracing. The state instituted a new platform in July, a new electronic platform for counties in the state to put in the contact tracing data. So that's why we can only go back to the beginning of July. But that said, it's really a great way to be able to pull out some of the data that we're seeing. And there's a couple of things that I just want to show you. One is that we're looking at high risk locations. So locations where people who are positive have been in the recent past. And people can be in multiple places, so it doesn't add up to the number of people. And not everybody has been to a location. But this gives you a picture of where people have been. The biggest category is working outside the home. We talk a lot about telework, and that's certainly important, but not everybody is able to do that. Indoor retail is the next category, 361. And then the 3rd through 5th are indoor dining, outdoor rec, and outdoor dining. And this helps us understand where cases have been, so we can get a sense of where exposure might have occurred, both in terms of where they may have picked it up and where they may have given it to others as well.
Nilesh, would you agree that the work outside the home category is a high percentage of those people are frontline and service sector workers who are then exposing themselves? And then that could be one reason why infection rates are higher among lower income workers and minorities.
That is absolutely one of the drivers of increased infection rate in lower income workers. And there's a couple of pieces to that. One is that there's really no substitute, right? They can't partially telework. They have to be on location every day. And the other is that they don't always have as much control over their workspace. So you hear more about inconsistent masking, inconsistent distancing, inconsistent hygiene practices. And so that's, those combinations tend to lead to increased risk in that setting.
Okay.
And then when we look at gatherings, so when people are just collecting outside of any business or structured space, we see that family gatherings are actually one of the highest risk, the highest risk gathering that is there. And this is really challenging because whenever we're with family, we want to relax, we want to let our guard down. We don't want to have to do all the things like distancing and masking, and if you've got a little sniffle or a cough, staying home and missing that gathering. But it's really just an opportunity to remind ourselves that even with family, we have to make sure we're doing the right things so that we don't get them sick too. Um, I certainly struggle with this with my family, with my extended family. Um, I really want to see them. We all really want to see our families, but we also have to take those precautions to make sure we're not spreading to each other.
So these numbers don't actually mean that the person got the coronavirus at this event. It just means that when they were contact traced, they reported these as areas where they were interacting with people.
Yep, exactly. Because we can't quite trace because there's an asymptomatic period. For people who develop symptoms, we call it the pre-symptomatic period. But because of that, it's hard to always nail down how you got it. And so part of the work is trying to understand, well, where have you been? What's popping up more commonly? Um, and so you're exactly correct. This is where people have been um, who are positive.
And I would just throw in here as well, as we're looking at this data, which comes from contact tracing, that this is the data that we were able to get from the state of Maryland, that they had basically crunched the numbers in the way they thought was most appropriate. We were not able to get the raw data until recently and get that in a form where we could do some of our own analysis. So I got my fingers crossed that you're going to have more information to be able to pull out of this, Dr. K.
That is what we are working on. So we're working on getting that crunch data from the Maryland Department of Health, so we can actually go through it and understand what we need to for our trends.
And this is important because when we make decisions about uh, where to um, where to try to restrict movement to stop the spread, we need to be able, it works much better if we can link it to data and people then understand that we're doing something because we know that it's going to slow the spread of the virus, not because we don't like somebody or we like some group of people better than another group of people. It's as much as possible based on data that we have. And when we don't have it, we have to listen to what other people around the country are learning to make those decisions.
This is just a summary of what we've been talking about for the past couple of minutes. Seeing a case rate increasing for 4 weeks in our county, slight increase in hospitalizations in the past week, with a longer than expected delay. Usually, like I said, we see it within about 2 weeks, and we think that that's due to a higher proportion of cases in the younger age groups. And we've been talking about the fact that the average age of who is getting infected has been decreasing. We think that's in part because people who are older or have other vulnerabilities have been taking additional precautions. We see that our percent positivity is increasing, and we talked about our contact tracing data. One of the questions we get a lot is how do you see the effect of changes? How are you making decisions? And I think that this slide will help to at least explain some of how we are trying to understand how actions lead to changes in the data that we can see. So I mentioned that we're really focused on the case rate, and what you're seeing here is that there's two lines. One, the green line is the case rate for our county, and the blue line is the case rate for the state, just for comparison. You can see that there's a section called relaxation. There's 3 arrows. Each of them are about a week apart. And that was in June when we were starting to lift restrictions. Those were restrictions on indoor dining, and then malls, casinos, racetrack, personal services. It's a week from the first to the second, from the second to the third, and then a week from this arrow to the bottom, to the lowest level we had. And then we started to see the case rate increase. And that's honestly, it's not surprising. We knew that when we started to relax restrictions, that we would see an increase in the case rate. And really the question was, would we be able to flatten out or not? We saw that we weren't really flattening out in early July. And so we took some actions that really weren't sufficient. We
Oh,
saw that we
we knew when we relaxed, though, that it would take a couple of weeks to show the
Mhm.
effect, right? So
Yep,
that's why there's a lag before it continues to go down
yep,
until that 2 week period, and that's when it starts to change. Okay.
exactly, exactly. So when we took these actions in early to mid July, there really weren't enough. And so that was when in July, late July, July 24th, we had the interventions around limiting restaurants after 10 o'clock, indoor, sorry, limiting restaurants indoor after 10 o'clock, um, limiting gathering size, 25 indoors and 50 outdoors, and limiting gathering in malls, but keeping all the restaurants and the stores open. Um, and what we saw is that about two, about 16 days really from this intervention is when we started to see it go down again. So about 2.5 weeks or so, which is in line with our general timeframes. Um, and then in mid-August, we saw that decrease.
Can I stop you right there and
Yeah.
say something about those interventions that we took? Because that was very controversial, because Anne Arundel did those interventions, but the state did not. And those interventions, we looked at the possibility. We knew restaurants and bars were a vector, a place where the cases were spreading. And we looked seriously at the question of whether to go back to only outdoor seating, curbside pickup. We knew that that would put people back out of work who had just gone back to work. I was very reluctant to do that. I think we all were. So we came up with this compromise of closing bars and restaurants at 10 p.m. because it was the bar activity where people weren't complying with the governor's order that they be seated, and that they be separated. They tended to congregate and start to have a little too much fun in the evening. And that's been done in a lot of jurisdictions around the country. And and so that was about 2 weeks after there that we started to drop. And you can see Anne Arundel County dropped much more than the state of Maryland, because the state of Maryland didn't take those same actions.
Yeah, and that's also when we did enforcement as well, right?
Right.
We wanted to keep those businesses open, but we also wanted to make sure they were operating safely. And while most were, with maybe a few issues, there were a few that were really just not. We're kind of operating as if COVID didn't exist, and that's
And,
that's dangerous to a lot of people.
yeah. And there's a line that's not on this chart that you could have on this chart, which is the unemployment filings for unemployment insurance. And
Mhm.
Anne Arundel County is about 10% of the population of Maryland. And at the beginning in March, we were about 10% of the new unemployment claims filed. As we moved down through August, through June, July, August, we dropped our percentage. It got down to 4, back up to 6, but much less than the 10% that our population is. And so I like to think that it's because we were careful about not putting more people out of work when we intervened. And that continues to guide us, because um, people being able to work is obviously a part of health as well, and
Mhm.
certainly a social determinant of health.
Absolutely. And then in mid August, we started to see the 4 week rise that I mentioned, which is community increase. If you're following the data, you'll also have seen that there was a kind of a steep increase that came down again, and that little increase was what we call a second rise, and we think that actually has to do with college testing. So a lot of students were heading back to college, and colleges were doing pretty much bulk testing as students were coming back. So that starting on August 20th, and so you got a whole bunch of students who weren't otherwise getting tested all of a sudden get tested at once. So we're still seeing that community increase even as that college testing spike goes away. And so that's the reason why we didn't actually move forward in stage 3, is because that governor's press conference was announced right around here as we were going up in our cases. We were shooting up, and that wasn't the time to open up additional businesses. That was our recommendation because of how rapidly it was increasing. And of course, as I noted, we continue to reevaluate the data and try to understand what's happening now. How do we understand the trends? And honestly, some of the trends only become apparent after a few days or a week, um, such as the college testing spike that we saw there. So I'm going to stop there for a second with the data, and I guess we can get to a few of the questions.
Yeah, well, we're at the right spot talking about the stage 3 reopening, and we do have questions on that. First one from Michelle. If Governor Hogan has stated we can open to stage 3, since our numbers are at an all-time low, that's not true according to this graph, but in any case, that's a perception. Why are you holding us back? Many have lost their jobs. We need to get back to as much normalcy as possible. From Michelle. Melody, same question. Why aren't we going to stage 3? And Dr. K just explained about the numbers going up, but there are people who look at this and kind of go, well, hospitalizations aren't really increasing, death rates not really increasing. So, 5 cases per 100,000, 15 cases per 100,000, what's really the big difference? And I would have to say that one of the things that I considered in this decision, and I will note that when the governor does a reopening, the way he has done it all along is he stated very clearly that not every jurisdiction should do it, that the jurisdictions who are seeing increases, the jurisdictions who aren't meeting metrics, should not be doing what the state does. So other states have, governors have divided the state into sections or said that if certain counties meet certain metrics, they will or they won't. In our state, the governor has given that authority to the counties, the health officer and the county executive. And so we looked at the numbers going up, but we also looked at the metric the governor had just given us a week before on school reopening. And I know we're going to get to that, but that metric was based on saying to do an increase in in-person, getting kids back to classrooms, in-person teaching, you should not increase that unless you're at 5 cases per 100,000 or below. And we weren't there. We had been there in the past and we were trying to get back down there. And so if our goal was to reopen schools, we needed to be figuring out how to lower the case rate, not add to it by additional openings. So it's as simple as that. Anything to add on that, Dr. K?
No, I think you hit it.
Okay. What specific metrics are you aiming for to determine when it's safe to move into stage 3? I would just say here that the stages, when you look at the governor's roadmap to recovery, there are stages, but we have never, the state nor counties have ever done a whole stage at once. There are lots of different parts to it. And so when the governor started into phase 3, he simply said that retail could go from 50% capacity to 75% capacity. In fact, when you go around to stores in our county, you don't see a lot of people being turned away because they're above 50% capacity, because it's the fire code capacity, and that's a very high number of customers. They have not increased the capacity for restaurants and bars in stage 3. And then movie theaters opening was part of stage 3, and some indoor and outdoor entertainment venues and higher numbers at those. So we could do some of stage 3 and not some of stage 3. So I wouldn't be stuck too much on the whole question of stage. Anything to add on that?
No, I think that's right. It's those were stages that we set months ago, and now knowing more, we have to really be more precise in how we move forward.
Right. Everybody has more information. Okay, this is definitely for you, Dr. K. Why do we use positivity rate as a metric? Ours is remaining slightly higher than average. Is it possible it's because we're testing fewer people and or only symptomatic people? Would rates be lower if we tested more people, regardless of symptoms? And do we believe that the positivity rates reflect the percentage of all county residents who are infected? That's from Richard.
The positivity rate is a really useful measure to help you understand if you're doing enough testing to identify. Ideally, you're identifying everybody who's infected. Um, the lower your percent positivity, your positivity rate, the more that means that you're really testing enough. That's why we've set 5% as a goal, and that's a goal that's been set by the World Health Organization. So it's not just one we set. We agree with that, and it's absolutely influenced by how much you're testing. If you test more, ideally you're pushing down your positivity rate because you've tested enough and you're not finding new positives. But it's also possible to test more and find even more positives. So you do get additional information from testing more. You're seeing whether it's actually you're finding more cases or you're truly saturated and you've tested enough. So it's not as straightforward in terms of what the effect is of additional testing, but it is a really useful way of knowing if you're doing enough testing.
Yes, there are lots of ways to look at the data, and we all look at it quite often and try Nilesh more than anybody, I'm sure, trying to figure it all out. Here's a question from Ed, and I like these questions. They're thoughtful. There seems to be no evidence that counties and states that have used lockdowns, quote, lockdowns, have had better outcomes than those that have allowed its citizens to make their own decisions that are best for their families. Please share the statistical evidence that supports not moving the county forward to phase 3. Many parents are struggling to juggle work and school responsibilities, and it appears the science is telling us that there's no benefit from not opening up our schools and businesses. So I'll let you take that one for sure, but I do want to say that there is absolutely a benefit to opening schools and businesses, and we don't even need science to tell us that, although I'm sure science could tell us that. But the question about comparing jurisdictions that have acted and those that haven't, I would encourage Ed to not only look within the county, but look at across the country at different states, and also look across the world and look at the United States compared to countries that acted sooner and in a more coordinated way. Our death rate is higher than anywhere else in the world. Most would say because we did not move soon enough, and we did not move in a national way. But what do you think, Dr. K?
That's correct. There is evidence from that the effect of stay-at-home orders and closure of non-essential businesses absolutely slows down the rate of spread. That's been shown in a variety of settings, and we see that in the data from the United States, and so that has to be balanced against the costs of those closures. But I think you bring up probably the most important point, which is that a national coordinated strategy would have been far more effective than leaving it to each state to make those decisions. And I think that's part of the challenge we have now, is that we don't close our borders as a state, and so our decisions are affected by other states. In the same way, we certainly don't close borders at county level. So, these are the challenges of we're trying to make decisions for Anne Arundel County, but we're also part of a larger texture of a state in the country.
We've got some good questions here. It happens to be from a reporter, Jacob at Anne Arundel County Patch, but I don't think we have rules against questions from reporters. So let's just, thanks, Jacob. I hope you're listening. Department of Health has recently focused on the coronavirus breakdown by race and ethnicity. A disproportionate amount of minorities catch and die from coronavirus. How does inequity in healthcare contribute to this? How do heavier minority populations in densely populated zip codes contribute to this?
So we definitely have been focusing on health equity. One of the big things that we know prior to prior to COVID is that there were health disparities, and we had identified health equity as a focus, and COVID really just tracks along those lines that already existed. Um, we know that racial minorities have had less access to healthcare and also have not not been treated the same way by the healthcare system. Less likely to have health insurance, more likely to have issues with access to housing or food or basic necessities. And so these all factor into how COVID has disproportionately affected those communities. We see for blacks in Africa, sorry, for blacks in Anne Arundel County, about 1.5 times as many cases as we would expect just on population, and the same thing for deaths, 1.5 times as many deaths. Um, for Hispanics, it's about 3 to 4 times as many cases. Because those cases are younger, the death rate isn't different than what we would expect, but that's still a lot of the illnesses and the consequences that we talked about at the beginning that people have to deal with going forward.
And I would just note that when we know that the virus is spreading at a higher rate in a community or in an area, that's where public health people focus, and they have to figure out what to do. And I think back on you knew this was going to be happening at a higher rate among African Americans and Hispanics, and you organized a group. The first call I remember, you had well over 100 county residents to give advice on how we could reach those communities and get the message out there. And at one point, the Hispanic rate was much even higher. I think we were at 15.
Yeah, positivity rate.
Positivity rate, right?
Yeah.
And we brought that down largely with community outreach and getting the word out, right?
And
increased testing.
Increased testing, increased community outreach, and listening to community members and leaders and asking them to be part of the messaging and getting the information to people, and also bringing information back to us so we knew what to do better, and working with other organizations. But that COVID-19 health equity initiative launched in early April and was a key part of our strategy.
Yep. Jacob also asks, there are an abundance of coronavirus statistics, but some can be difficult to understand for people who aren't health experts. What coronavirus metrics would you tell residents to check to easily gauge the progress of the virus?
So I think the case rate is the one that we look at the most. We look at hospitalizations. We look at percent positivity. And we don't talk a lot about contact tracing and case management because we have done that from the first day for 100% of the people. Not every place has done that. We were the only.
Nowhere has done that except us, right?
Yeah, so we don't track it as a measure because we built that into our pie. But that's been a key part of our approach, is to not just to do the contact tracing, but to provide the case management needed to make that successful. So helping people with food, or even rent or housing, whatever they needed, really, to make sure that they could safely isolate and quarantine.
Okay. Hospitals are seeing low numbers for acute care and ICU. The numbers are not climbing despite our positivity rate increasing. Which number is more important? From Julia.
They're both important. We kind of focus first on the acute care piece because that's the number that would go up first before the ICU. So if you had to pick, I would pick that number. But I think that's if there's one take home on data, the take home is that you need all of it to paint a complete picture. I think of the old fable about the blind people and the elephant. Everybody is touching one part of it, but you kind of need all of that to paint a full picture of what's happening.
Okay, one more data question. Why does JHU, Johns Hopkins, put Maryland at about a 6% and therefore not meeting WHO's reopening guidelines, and yet the state of Maryland is reporting 3.7% positivity rate? Basically, why are they so different? Can you explain the discrepancy and by which metric the county's making decisions?
Yeah, this has to do with how data is calculated. So for those who are looking closely, our percent positivity in the county, the way we calculate it is slightly different from MDH, is slightly different from Johns Hopkins. Johns Hopkins has a way of measuring it that they're applying to everywhere in the country because different states are reporting in different ways. And it has to do with using a 7-day average up front in terms of cases and tests. Maryland Department of Health does its reporting based on the day that the results were obtained. And we at the Anne Arundel County Health Department do it by the day that the test was run. The day that the test was, the day the test, the sample was obtained. So Anne Arundel County sample obtained, Maryland Department of Health, day we get the result, and Johns Hopkins 7-day average. And so you see slightly different numbers from that. It is a bit confusing. That's why we've stuck with our measure. At least gives us the continuity to be able to make decisions.
Here's a basic one. People are aware that COVID-19 is out there and they could get it. Isn't it well past time to allow people to just choose how to go about their lives?
That's a great question. People are aware of COVID-19, but I will say that I don't think that everybody, in our conversations with folks, I don't think everybody has fully understood what is needed to actually prevent its spread. That's why we continue with the masks, distancing, and the hand hygiene campaigns. But I think the other thing that's more important is that our decisions don't just affect ourselves; they affect others, right? If you get it, and if you say, I don't care, I get it, I still care about your health, but I understand your point. But the problem is that you're then likely to spread it to somebody else, and they didn't necessarily have a choice in that. And that's why this is a pandemic like this is really a public health issue, because your choices affect others as well.
I know you have some more slides having, I think, largely to do with schools, right?
Yep, that's right.
Let's jump into some of those.
Let's do that. Give me 1 second to take over. So we talked about reopening schools as a priority. It's critical. Schools are critical for the development of children, for their not just their cognitive development, right? What they're learning in school from an academic standpoint, but also from their social and emotional development and their physical development. And we also know that the importance it's much greater at the younger ages, where a large part of the content of school is geared towards the social, emotional, and the physical development in addition to the cognitive development. And that's why we're working on defining metrics for reopening and putting into place the mitigation strategies to provide hybrid in-person learning. And I think the key part here is that the lower the case rate, the better our ability to keep students and staff safer and keep school open. The one thing that I keep saying is that it's not hard to open school, it's hard to keep them open. And that's really what this is about. This is about getting the conditions in place so that we can, once we open schools, we can keep them open, ideally for the duration of the school year. And so we've been having discussions with the Maryland Department of Health since July, mid-July, around metrics and protocols to do that. And they in conversation were saying that they would be coming out with statewide guidelines, and that's preferable from our standpoint that there's uniformity across the state. About 3 weeks ago now, they provided some guidance. It's a broad framework that looks at testing positivity rate and the new case rate, and says that ideally your case rate is less than 5 per 100,000, but that between 5 to 15 per 100,000, there's a range of strategies you can use. While this was a helpful framework, we really need to put some more details into that. to be able to actually open schools up. Um,
Can you go back to that for just
yeah,
1 second? Because I know there's been a lot of confusion about this, that some
yeah,
people heard the governor in their mind say, school should open now.
hmm
That was what they heard. What he was saying clearly was, we need to work to get schools open.
hmm
And then you saw the map that the governor showed of the counties and which ones were doing the right thing and which ones weren't. Anne Arundel was
hmm
one of the ones doing the right thing in that we had a plan and we were starting to reopen. And when you look at this, when you get below a 5% positivity rate, um, you can um, you can jump into the chart that goes from expanding in-person programs to limited in-person programs. But to be
hmm
able to really expand in-person programs, which is what we all want to do, um, they're recommending you not do that unless you're below 5 cases per 100,000. Um, and that's pretty darn low, and that's what we're trying to get to. And I
yeah.
know right now we're having conversations, and you've got this new scientific advisory group really looking at this,
hmm
and to see whether there's a way that we can do that, maybe with a little bit of a higher rate than what the governor's saying there.
hmm Yeah, and that's
Okay.
what we're looking at is um, above 5 per 100,000. How can we open and how can we be more nuanced? And I think the key here is that there's different conditions, right? There's different groups of students that have different needs, and how do we address that? And so we are starting the school year with saying that given the case rate that we're at right now, um, special needs students, technology students, English language learners, there's really for them, there's a component that has to be in person because of their needs, and that's they can open up right now. That's what the governor was saying. That's what in our conversations with the Maryland Department of Health, that's what the governor was saying is that some you can make decisions to open some part of school up based on these determinations, and we absolutely are starting the school year that way. But additionally, we know that it's really different for elementary school, the K through 5, middle school, 6 through 8, and high school, 9 through 12. And there's a couple of things that are different about each of those three groups. One is that for elementary school, particularly, so pretty much under the age of 10, um, they don't they don't get sick as much. They don't get symptoms as much, and they don't transmit COVID as much. Um, but for those over 10, they pretty much behave like adults in terms of getting infected and transmitting that. The other thing that we think about is that cohort size or who's in your pod or your island, right? We've talked about who's in your pod. For elementary school, your pod is your classroom. And, kids used to go to lunchroom and they had specials and all that kind of good stuff. But in the setting of COVID, we could keep kids in one classroom and the teachers as well. And so their cohort size is in the tens. Usually it's about 20 something, right? Um, that goes up significantly for middle school, where your cohort size is your grade essentially. You're taking generally you're taking classes just with other kids in your grade, but you're moving from class to class, right? You have periods, so you're with a different set of, let's say you're in sixth grade, you're with a different set of kids, sixth graders from period to period. So your cohort size is now in the hundreds, so it's a lot larger. And then in high school, the grades are mixing. Um, the cohort is essentially the entire high school at that point. So your cohort size is in the thousands. And so as we're looking at developing these guidelines, and as County Executive mentioned, we have our scientific advisory group, and we met with them yesterday. We're really going into more detail about at what case rates within that 5 to 15 can we open, and how do each of those case rates apply to the different situations, the elementary school, middle school, and the high school? And there are going to be differences because of the two things that I mentioned. They're how likely they are to transmit, and also their cohort size. So we're looking to have those metrics out in the next few weeks, um, that and we'll be certainly be talking more about them in the coming weeks.
Yeah, looking forward to that. And we all recognize that virtual learning is less useful the younger you get.
Mm-hmm.
It's really hard for a first grader to do much that way. So,
Yeah.
okay. So, can I ask a couple more questions, or you got more slides?
Nope, that's it. Let me.
Oh, that's it for slides. Okay. All right. So, yeah, I do want to say that in addition to all of the scientific work on opening schools, um, we met with Teachers Association of Anne Arundel County about 3 weeks ago, or maybe it was 2 weeks. You and me and Dr. Arlato, and listened as teachers expressed their concerns. And I want to read one question from a teacher named Lauren for you. I'm an Anne Arundel Public Schools elementary art teacher. I teach in 3 different elementary schools. I'm extremely concerned about that level of exposure if elementary goes back. I could potentially spread COVID from one school community to another. Many other AACPS employees also travel to different schools throughout the week. My question is, so this teacher is more concerned, it sounds like her concern is about her as a spreader. My question is, what will the policy be for schools to report positive cases and possible contact with those individuals?
So what we are what the school is going to be doing is going to be reporting to us any student or staff member, um, teacher or other staff member who's positive. And the reason we want that to happen is while the students are certainly Anne Arundel County residents, not all the teachers and staff are. And from a contact tracing perspective, we wouldn't be notified if, let's say, this teacher didn't live in Anne Arundel County. We wouldn't be notified, right? It would be whichever county they lived in would be notified first. And so what we ask as a policy is that students and staff report positive to the school, and the school reports it to us so that we can quickly do that contact tracing, um, and identify risk, do testing, do quarantine, isolation and quarantine, and provide any supports. So that's how we're going to be handling the contact tracing in the school system.
Um, I know that I saw a question about this further down, but I want to make sure we get to it, and I have the same question. So some of the private schools in the county opened with hybrid systems, partly in person, partly virtual. You were criticized at the time because you said that they could only open if they gave you a plan for how they were gonna reduce the spread, and that your staff would review the plan and approve it, and then they could go on a list of being approved to open. How's it been working?
I think it's been working really well, actually. So when we that was in early August when we said that we required a plan. Um, I think we got over 45 plans at this point. A lot of them came right then. And what we found is that while most of them were pretty good, almost all of them had a few areas that needed to improve. Um, Mostly around contacting individuals, assisting contact tracing, communications, and then dealing with inhaler use, which can spread virus. And so that kind of collaboration was really important for 2 reasons. One, to improve the plans for those schools so they could be more successful. And second, it opened up the line of communication. I mean, we're in routine communication with at least 4 or 5 schools each day, answering questions, working through problems. And I think it's been actually better in the long run for our communication with the schools.
Yeah, and I heard a lot of positives from the administrations in those schools and the parents, because they had the stamp of approval, that they had jumped through some hoops and that they were being responsible, and it gave teachers and parents and administrators and everybody a level of comfort. I found it um, almost funny that we were being attacked politically for it, as though it was some sort of a political move by politicians who thought that it was an overreach on the part of the health department to be, working with the private sector to stop the spread of this virus, because that's exactly what you've done, and you've done it with private businesses as well. And I know it's incredibly labor intensive for your staff, but I have no doubt that it saved a lot of lives. So thank you for doing that work. Um, can you address, well, can you discuss if children are starting to transmit the virus? Private schools and daycare have been open for some time now. What is happening, Meredith?
Yeah, children do transmit the virus. As we were mentioning, those younger than 10 um, tend to tend to transmit it less than those older than 10. So that's certainly something in their favor of opening elementary schools. Um, we'd estimate that we've seen a number of closures. We've seen a number of cases in daycares as well, right? We've had the experience with daycares. Um, and so we're continuing to track those types of outbreaks, and we're really trying to understand what the lessons learned are, and we can share them with others.
It's getting dark in your studio, Nilesh. I think the sun's going down outside.
The sun is setting on me.
Get your lighting crew to work. There we go. Now we can see your beautiful face. Let's see. There's a lot here on schools. Are you prioritizing getting elementary school students into the classroom, particularly our K-2 learners? These students do not benefit from virtual learning. Are plans for a hybrid return to elementary school in place? Kristen.
I think you've identified our priority. Even within K-5, the younger they are, the more important it is to get them back.
So that's the plan that's being.
Yeah, as the father of a second grader, I can assure you I know exactly what you're talking about.
Okay. Lisa says, I'm not sure people understand the risk of moving too quickly. This is on schools, especially when it comes to our teachers, staff, and kids. Do you think we will stick to the original February 2nd school start? That was not actually a commitment, but I think some people believed that nothing was going to happen until February 2nd. And what do you think that opening will look like? Totally in person or hybrid or still virtual? If in person, what safety measures will be put in place? I know our middle and high schools are particularly crowded.
Yeah, so February 2nd was, I think, probably the longest possible we would go. We're really targeting a fall reopening, October, November. That's ultimately up to the school system to make that decision. We're really trying to lay out the conditions that will allow schools to reopen. Part of that is understanding the steps that need to take place. So how are you going to maintain the distancing? What do you need to do to change class sizes? Does that mean that you have an option for doing virtual, or where you bring in only half of the class at a time? Those are the things that are being worked out right now to make sure that the conditions are promote distancing, mask usage, both for staff and students.
Will the county keep a tally of how many coronavirus cases each school has when they reopen? And I guess yes. A follow-up question will be, will it be published?
Yeah, we're certainly going to be tallying that. That's 100%. We need to, and we actually had some discussion about this from the scientific advisory group. We just need to figure out how to share that information in a way that is both informative, but also addresses privacy needs for students and staff who may be positive as well. And I think that one of the things that we're definitely looking at is the distinction between somebody being positive who's a student or a staff and an outbreak happening in a school. The best way to think of this is on day one, nobody's been in school yet, but somebody's going to show up who is positive, right? Because there's community spread. The real question is going to be, how do we catch that, and how do we make sure there isn't spread that's happening in the classroom itself?
Okay, Kathy says, I am a teacher at AACPS. I feel deeply troubled that AACPS is now setting up teachers to be the bad guys who are standing in the way of in-person instruction. I simply cannot understand how the safety and welfare of our students and staff can be jeopardized during this pandemic. I feel like we as teachers are being put in an impossible position. How can you help us? And I'll start on that, which is that unfortunately, there are some more on the political side, I think, who the governor was in his press conference pretty critical of teachers' unions in general, as though it's the big bad union that's telling teachers not to work. And when we had our call with the teachers, there were 100 or more on the call of Anne Arundel County teachers. My own view was that these were very legitimate concerns for the kids, concerns for the teachers, concerns for what's right for the community, and that in fact it's the teachers that you, Nilesh, and Dr. Arlotto have to listen to and are listening to, because they're the ones who know what goes on in a classroom and know where the risks are and know how to manage things. So my hope is that, yes, that nobody is scapegoated, but that everybody works together to try to figure out how to do this safely. And that I think your role, Nilesh, is incredibly important, because you're coming at it from a completely non-political. You're not management, you're not labor, you are doctor, and so I hope that you can help in that.
That's part of the role that we see the health department playing in this, is how do we make sure that both students and staff, and we've been really clear that both those groups need to be able to come back. And we're in a position, because we've been working with all sectors in the community to understand what safety measures are effective and how to implement them. That's why we're working with AACPS to make sure that we can bring folks back safely when we do.
Okay, let me jump into businesses. We've been on schools. Then we have sports and fitness. We're not going to get through all this stuff. We were supposed to end at 7, weren't we? Let's do a few more, though, okay? You good for a few more?
I'm fine.
All right.
Well, once the sun goes down, I don't have any lighting.
Yeah, last I heard you had a family. Is that not true anymore? Yeah, it's been long hours for everybody. Okay. Wow, these are some great questions. I wish we could do them all. Let's go to the business section here. When will you let bars stay open after 10? Dave. I wonder if Dave is a bartender, or maybe he just likes to go to bars, but.
Yeah, bars are a big challenge. The optimal setting in a bar involves alcohol, which makes people tend to be a little more friendly with each other, close the space. It's one of the reasons that we identified as a higher risk location, and actually the CDC identified it as a higher risk location just this weekend. As they were going through data, what they found was that bars and restaurants were 2 times as likely to be represented as a place that people who were cases had been compared to almost any other activity. It's a big challenge. And I think that part of what we're thinking about is how do we help bars and restaurants and the workers there, recognizing that balance between preventing the spread, but also people's economic well-being.
It's been tough. I mean, I spend a lot of time talking to our team at economic development. I've had lots of meetings with the local chambers of commerce, and while they're much happier than what Baltimore City did, which really pushed the rates down drastically in Baltimore City when they went back to no indoor dining, closed their bars and restaurants indoors, and now they're working their way back again. So they really stopped a huge spike in Baltimore City. glad that we didn't do that. But the 10 p.m. closure does crimp businesses, and we don't like to see that. But it seems to be very effective, so we may have to live with this for a little while. When do you foresee the county going into phase 3? And if not anytime soon, we've talked about that it's not necessarily a one thing, it can be parts. What can we do to work together? This is from Joe, so that you allow my movie theaters to reopen sooner.
I think this is where the we're all in it together kind of thing comes into play. The more that people use the masks and distance, um, the less transmission we'll have, and the better we'll be able to open additional sectors. I know that it's hard. I know that it's, to be blunt, it sucks. But it's how we're going to be able to control the virus enough to bring back the activities that we all really want to see come back.
I mean, I do have to say that when we've made these decisions in the past, it is relevant when an industry, they come to you, they come to us. Often it's a trade association, and they make a case for how they can operate safely, and they put a lot of work into that. I mean, what happened at the casino? They put a huge amount of money and work into, separating people in a way that they weren't able to interact. And had they not done that, they probably would not be open. They did do that, and they were able to open. But at the same time, it's also not always fair, because as you've often said, it's about limiting risk and keeping the numbers low. And so in the beginning, when Walmart and the big box stores were open, but the little stores were all closed, that was absolutely not fair. But a determination got made that one was an essential business and one was not an essential business. And the way the math worked, that somehow the numbers got pushed down. Unfortunately, it's not always fair. Sometimes it's just the way things get categorized by the state or the feds, or in some cases even us. But when we do it, we really do try to pick the things that that science shows will limit spread and allow those to happen, but not others. So I can safely say that we're still looking at all of this, and we'll continue to look at all of this constantly. We have our recovery work group meeting on Thursday, and we'll continue to look at it all. But we've gotten your stuff, Jason. We know what you're talking about. Okay, let's just do one more, because I know it's getting kind of late here. In the sports category, how about oh no, let's do a seniors and nursing home. When will nursing homes be reopened for family? What metric is being used for this? I think, we don't talk about it a whole lot, but anybody who's got family in a nursing home right now and has not been able to visit, it's not easy. So is there anything being done on that front?
Yeah, so the guidelines for how nursing homes can open up to families, that was set by the state. I think that was about 6 or so weeks ago at this point, maybe more. And it outlines a pathway for each nursing home, what they need to see in terms of no spread, having the safety measures in space, and then essentially a testing that they're ready to move to the next stage to allow family. So that's a question that's actually, you should be asking the nursing home where your loved one is, where they are and what their plan is, because it really is up to them to figure out how to move along those stages that the state set out.
Do any epidemiologists work for your health department?
We do have staff, and we work with the Maryland Department of Health epidemiologists, and we've also had a lot more contact with staff at the University of Maryland
You said yes, though, right? I mean, you have everything. Yeah. I mean, you have a whole department, right? Yeah. Yes. Okay. All right. I'm going to pick one more here, and that's going to be the final one, I promise. Let's do a sports one. Why can't high school sports happen when rec and travel leagues are playing? We're told by the superintendent that a plan to get high school sports back would be announced by the first day of school, and this did not happen. Kelly.
The high school sports are actually controlled by the state association. We're not a part of that decision-making process. I know that the school system is looking at how to bring practice back in line with the state guidance on that. And I think it was last week that that state association put out a calendar for when competitions would begin in 2021. So that's how that decision making is being done. It's done at the state level and implemented by each school district.
And I would just say that I remember when the decision was made to allow sports to go ahead at our county rec and parks and their leagues, and it was done partly following the state's return to play guidelines. There was, of course, a lot of controversy over football because it was considered high risk, and that was the one part of phase 3 that we did go into. I guess you could say that the sports were classified by phase for football, but it did seem to me a little bit arbitrary about which sports were allowed and which sports were not, based on decisions that were made at a much higher level than us. And I just want to say that my kids play soccer, and it was a risky thing to do, and you did it. I know you sort of approved it partly because it was so important for the health and mental health of these kids to be able to get out and play. But it really, I worry as I watch that about the spread, and hope that the virus does not, we don't have outbreaks on sports teams. And I know that every team has a person who's supposed to enforce the rules with everybody, all the parents and and the coaches, and a lot has to do with the coaches taking it seriously. I know it's no fun to coach with a mask on and try to get those kids to hear you, but they all huddle up and they need to put their masks on when they do. So far so good on the sports front, right? We haven't had any outbreaks.
We're doing okay. We've seen some cases on sports teams, but we haven't had an outbreak, meaning spread between members yet.
Okay. So yeah, every one of these areas, it has to be closely monitored, and it's no fun. We're all tired of it. It will be over eventually, right?
Yes, it will. Yes, it will.
So let's hang in there. And I want to end just by quoting. Remember that we had Dr. George Everly with us early on, talking about the mental health aspects of this. He's an expert. He lives in Severna Park, but he's an expert on recovery from disasters. And he was talking about what the recovery from this might be like. And the thing that he had learned going around the world working on this issue was division delays recovery. So whatever the disaster is, when there are political divisions, when there are tribal divisions, when there are attitude divisions, if people don't stick together, they tend to delay their recovery. So I think that's absolutely true in this case. And it's hard to do, but Governor Hogan said from day one, we're all in this together, and we just have to keep remembering that, because that's how the virus sees it. And I want to thank everybody who's listening. Thank everybody who's working to slow the spread of this thing, and keep speaking up. We're listening, but the decisions are not easy. So thank you.
Thank you.